Hello, I am Dr. C. Rao, consultant diabetologist at WISE Diabetes and Research Center, Fatima Nagar, Pune. So I'll be discussing a important case today. This is a poorly controlled diabetes with hypoglycemia risk. This is the topic. So we have a 50-year-old type 2 diabetic lady. For 2 years, patient came with frequent history of hypoglycemia events in the past 2 months. Medication is metformin 1000 milligram twice a day, sulfonylurea 2 milligram glimepiride twice a day. Laboratory investigations, HbA1c is 8.2%. The eGFR is 88 ml per minute. LDL is 90 milligram percent, HDL 36, triglyceride 126. The SGPT is 33, creatinine 1.1, eGFR is 65 ml per minute. Physical examination, the BMI is 31, the blood pressure is 120 by 80, heart rate is 78. So to optimize glycemic control with cardiorenal protection are the primary treatment considerations in this patient. And HbA1c goal for many non-pregnant adults of less than 7% is very important. On the basis of provider judgment, that is the doctor's choice and patient preference, achievement of lower HbA1c levels, say 6.5%, may be acceptable if this can be achieved safely without significant hypoglycemia or other adverse effects of treatments. So in the 21st century, type 2 diabetes has reached epidemic proportions globally. Indians have a tendency for earlier onset of type 2 diabetes, leading to an accelerated risk of developing complications, making it more essential to address the pathophysiology early in disease course with available novel therapies having minimum risk of adverse events. So strict glycemic control is very, very important in patients with type 2 diabetes. Sulfonylureas play a very important role in glycemic control as a direct extension of their mechanism of action. However, the risk of hypoglycemia is increased, and this risk may be further increased in patients with renal impairment, which is a common comorbidity associated with type 2 diabetes. Hypoglycemia is a major concern for users of sulfonylureas. Magnitude and severity of sulfonylurea-induced hypoglycemia range widely across studies. There is a strong rationale for combining a DPP-4 inhibitors and CV protective class of SGLT2 inhibitors in patients with type 2 diabetes, because two drugs exerting different and complementary glucose lowering effects, you get more benefits. Furthermore, the increase of glucagon levels induced by SGLT2 inhibitors may be blunted by the co-administration of DPP-4. Clinical evidence shows that the combination of SGLT2 inhibitors and DPP-4 inhibitors combination is an effective option for management of type 2 diabetes, providing HbA1c reductions of around 1.1% to 1.5%, and the weight reductions of approximately 2 kg when added to metformin, which is its primary place in therapy. In clinical practice, we have seen patients achieving even higher weight loss. We have seen patients achieving weight loss of 5 to 8 kgs on a regular basis. The American Diabetic Association recommends initial combination therapy should be considered in patients presenting with HbA1c 1.5 to 2% above target, considering absolute effectiveness of most oral medications rarely exceeds 1%. So if a patient's HbA1c is 8.5, so adding only metformin on day one will not be able to achieve the targets, but adding a combination from day one, where we know we have to get the HbA1c down by 1.5%. So if you can add this combination of SGLT2 with DPP-4 inhibitors along with metformin, you will get the result. So this unique combination lends itself readily to early treatment intensification because of good tolerability, low risk of hypoglycemia, possible weight loss, and minimal treatment burden. Clinical experience with DPP-4 and SGLT2 combination show that they can be used with a good safety profile and a low risk of adverse events, that is hypoglycemia and weight gain, even when added to metformin, which is a particularly important finding for clinicians. And in our practice, this really makes a big difference for the patients. A reduction in incidence of genital infections associated with SGLT2 has been reported with a DPP-4 when a DPP-4 is added, perhaps because of a better glucose control, although other possible mechanisms remain to be investigated. So to summarize, a person who presents with a higher BMI, whose HbA1c is say 1.5% above the target of 7, and where you see there is a early loss of urine protein, the eGFR has just started falling. The patient is very busy with very poor meal timings. For example, a bank manager. These are the patients where you should not think only about glucose control. Along with HbA1c reduction, you have to give other benefits like weight loss, prevention of hypoglycemia, protection of the kidney and heart. The best data today for renal and cardiac protection is with the SGLT2 class inhibitors, class medicines, and the GLP-1. So to give a combination which is commonly available now in our country, that of SGLT2 and DPP4, especially we have empagliflozin and linagliptin combination. This adds value to the patient. The benefits that you will get in your patient subset is good HbA1c reduction, weight loss, renal protection. Many times we see urine albumin create ratio which is increased, loss of albumin in the urine is many times either reversed or the progression is delayed of renal pathology. So this combination, and also there is a very good data on cardiac benefits, especially hospitalization for heart failure. So all these benefits should be provided to the patient in the long term. There is also a very good data of durability of effect. So there is data of quite some, almost a year or more, of the HbA1c reduction being maintained without increasing in dose. So these are the benefits of this combination which we should be giving to our patients. Thank you.